All right. Well, thanks again. Welcome along to the Coaching Corner on July the 1st. As always, if you have any questions or comments to make, feel free to say g'day as we go. And if you want to say something offline at the end of the presentation, I'll let you know when we are stopping the recording. Tonight's topic, thanks to Brian and his great suggestion, because I was searching for a topic, tonight's topic is how to scan the pancreas. So we will kick straight into it. Now, the pancreas for me as a sonography student many moons ago was just this real vague, was the one thing I just could never, ever see. And my mentor would say, yeah, just stop the picture there. And I'd be like, where is it? I cannot see it for the life of me. And for me, it was just like this fuzzy object that kind of was in a whole heap of other fuzz, and I could never really delineate it. And you know, I wish someone had just drawn some pictures or you know, had these fancy tools that we've got on the PowerPoint now where you can color it in and show me. But it was always a struggle to see the pancreas. And I think that one of the things about the pancreas is that on ultrasound, not a whole lot goes wrong with it. There's a few, and tonight I'm just going to discuss a few really common, the more common pathologies that you can see. It's not a comprehensive list by far, but these are the things that I've seen. And even though I've seen these things, it's only 2 or 3 of each one in my whole career. So we'll start with a bit of a refresher on the sonoanatomy. We'll look at the scan technique. I'll suggest some scanning tips, and then we'll look at the sonographic signatures of some of those common pathologies. So up front with the sonographic anatomy. The pancreas is an oblong-shaped organ that's positioned at about L1 in the transpyloric plane. With the exception of the tail of the pancreas, it's retroperitoneal organ, and it has several direct anatomical relationships to the things around it. So the duodenum is the trickiest thing insofar as it's this C shape that sort of curves around the head of the pancreas and can sort of hinder our visualization at times, because if the duodenum's got bile gas in it, then we can't see through that so well. The common bile duct also descends behind the head of the pancreas before opening into the second part of the duodenum. If we look at where the stomach sits in relation to the pancreas, the stomach overlies the pancreas. So when we put the probe on, we will see this, the stomach in front of the tail of the pancreas, and that's why we can't see it so well at times. And so, you know, if we use some graded compression and just firmly press, sometimes we can squish the contents of the stomach out of the way. And in fact, there are times when we can use that to our advantage and get our patient to drink some water to fill the stomach up with water so that it helps us to see the tail of the pancreas. And I've had mixed success with that. It always works better in the textbooks, I find. When we look at the cross-sectional anatomy, you can see where the stomach is sitting in relation to the pancreas. And you'll also notice that we've got the aorta, the SMA, and then the superior mesenteric vein here. And those become our key anatomical landmarks for finding the pancreas. There are several major vessels, as I was just saying. We have the aorta and inferior vena cava. They pass posteriorly to the head of the pancreas. The superior mesenteric artery lies behind the neck of the pancreas and anterior to the uncinate process. Posterior to the neck of the pancreas, we have the splenic and the superior mesenteric veins that unite to form the hepatoportal vein. And as it journeys from its origin to the celiac plexus and the splenic hilum, the splenic artery traverses the superior border of the pancreas. And so again, these key landmarks here of the splenic vein assist us in trying to figure out where the pancreas is actually lying. And on this example, you can see the see-through diagram. So the IVC and aorta pass behind, but the superior mesenteric vein here and then the splenic vein are key landmarks in finding the pancreas and delineating the different parts of the anatomy. So you'll notice on this picture here, the ultrasound cross-section, we're transverse in the epigastrium here, and we find the aorta and the IVC, and they're pretty easy. And easy to recognize because you're used to looking for those when you're doing the searching for an aneurysm, or even when you're looking at the heart, you're used to looking for the aorta and the IVC. Sitting in front of the aorta is the superior mesenteric artery. And these are like the key landmarks that you need to look for, with that splenic vein, superior mesenteric vein, and the splenic vein sort of draping across the front of the superior mesenteric artery there. That superior mesenteric vein and then the tail of that in the splenic vein here help us to find where that tail of the pancreas is, because otherwise it just blends into everything. And that yellow shaded area indicates where the head, parts of the head, neck, and body of the pancreas are. Now, the pancreas is typically divided into the 5 different parts. The head's the widest part of the pancreas, and it lies within the C-shaped curve created by the duodenum and is connected to it by connective tissue. The uncinate process is a hook-like projection of the inferior aspect of the head of the pancreas, and it extends medially to lie beneath the body of the pancreas and lying superior to the mesenteric vessels. The neck is between the head and the body of the pancreas, just in this portion here. The body is centrally located and crosses the midline of the body to lie behind the stomach, and the tail is the left end of the pancreas, which lies within close proximity to the hilum of the spleen. So when we look at the images here, this is two people's pancreas, obviously, and it's got quite a variable echotexture, but we can see in both of these, the splenic vein here and over here is key to sort of helping us figure out where's the rest of the pancreas. So the normal appearance is usually that it's homogeneous and also almost isoechoic with the liver. So if we look at the head of the pancreas here versus the liver tissue, you'll see that it's almost isoechoic with the liver. Sometimes it can be hyperechoic because of fatty infiltration. So this is on a very young pancreas, and on an older one where it's a little bit more echogenic and there's probably a bit of fatty infiltration. The size of the pancreas varies with age and history. The approximate normal dimensions are that it's about 35 millimeters anterior to posterior in the head. So up here, the neck is about 10 to 15 millimeters, and the tail about 20 millimeters thick. The pancreatic duct also runs along the length of the pancreas and unites with the common bile duct, forming the hepatopancreatic ampulla ovata. This structure then opens into the duodenum via the major duodenal papilla. The secretions into the duodenum are controlled by a muscular valve, which is the sphincter ovati, and it's surrounded by the ampulla ovata, acting as a valve for those gastric juices. Now, in the normal pancreas, you don't often see the pancreatic duct too much, and usually when I do, I'm starting to think is something else going on. And having said that, we've had a patient this week who just had the most beautiful looking pancreatic duct that I wish I'd got some pictures of. It's clearly part of normal pancreas, but if I do see it so clearly, I start to think about what might be going on, rather than I guess with some of the great technology that we have, everything's becoming much more visible. So let's look at the scanning technique. And the first thing we need to think about is, as always with anything we're doing, is what are the 3 Ps? We're first going to pick the right probe. And in this case, we want to use the curved probe, choose an abdominal preset, and we want to position the patient supine on the table. Now, there are some techniques to help visualize the pancreas that we'll go into in a bit that can, where you stand the patient up, and that can help you move the bile gas in the stomach and the transverse colon so that you get clearer visualization of the pancreas. We position the probe high up in the epigastrium. So we're looking to see where the V of the rib cage is there, and we position the probe quite high and then slide inferiorly to try to find that those vascular landmarks of the aorta and the SMA. You may need to apply quite firm pressure here to help displace some of the gas. And then we want to adjust the image depth so that the aorta is on the bottom of the screen. Typically then I'm just tilting the probe towards the feet a little bit. So we've got a little bit of downward tilt to help see the, particularly looking at the head of the pancreas. You can use both the transverse and the sagittal plane. So, oh, hang on, I think we've missed one here. So we can use the longitudinal plane as well. And what you'll find here is that you need to be slightly right of midline. And again, we're looking for that vascular landmark of the splenic vein to help outline this. So the pancreas is around in this manner here. Now, to help me figure out where the tail of the pancreas is, what I need to do is just hold the probe marker side of my probe still, and then just slightly, and with that downward tilt, just slightly rotate my probe, the non-probe marker side, so that it points to about 2 o'clock. And what that does is just draw out the tail of the pancreas. So we can see the splenic vein here, and then we can see the tail of the pancreas around this way. And I find that tiny little bit of pivot movement helps me to fan out that tail of the pancreas. And you'll notice in this anatomical image again, the direction that the pancreas lies in, with the tail of the pancreas sort of pointing to the 2 o'clock position, which is why we need a slight bit of rotation on our probe so that we can lengthen out the pancreas. Now here's an example of a scan. I've started in transverse, and just as I rotate the probe a little bit, you can see the tail of the pancreas become much more visible just through here, and it crisps up the image nicely. So we're aiming to just try to lengthen out that splenic vein to see the tail of the pancreas there. This is a pancreatic duct in a normal person. So you can see that there's kind of a really thin sort of hypoechoic area through here, and that's just the pancreatic duct. As I said, you don't always see the pancreatic duct on normal pancreases. What's the plural of a pancreas? I've asked that question today when you talk about 2 pancreases. Anyway, we can come back to it. Anyway, so some scanning tips here. If you are having difficulty seeing the pancreas, and particularly the tail of the pancreas, you may need to fill the stomach up with water, and I do suggest clear fluids. If you've got orange juice or things with floaties in it, it doesn't work so well. And certainly if your patient has eaten not that long ago, you know, the water is just going to stir up whatever was in their tummy anyway, and so it can make it a little bit messy. But what you can do is roll the patient onto their right side so that the gas moves up and out of the road. And the theory here is that if there's fluid in the stomach, you distend the stomach, you have a nice black, like how the bladder works for the uterus. You have this fluid-filled stomach that helps act as an acoustic window for the pancreas. Now, as I mentioned earlier, it's all good in theory. I haven't had a whole heap of success with this when I've needed it. I've occasionally had patients who've had a drink before they come in, and it happens to have worked, but it hasn't worked when I've needed it. But that might just be sod's law. Now, the other thing you can do is stand the patient up and scan them in the erect position. And again, what we're doing here, just when we stand up, the transverse colon will sort of move down slightly, which means that we get rid of some of the bowel gas. And the other thing you can do, and this is my boy who's very good at doing the caterpillar stomach maneuver, but he can do that pregnant belly move. So ask your patient to push their tummy out, or the Valsalva maneuver, because again, that just pushes the abdominal contents down a little bit and moves the gas so that we can create a better window to see the pancreas. And I think the other thing that we do in an ultrasound department is to scan the abdomens in the morning. So they haven't been chewing gum, and they haven't been having lunch, and they haven't been talking all day. So we reduce the bowel gas that way. So, you know, the abdominal patients are usually booked preferably in the morning, and they come fasted, and that all helps to make for better imaging. Often though, in an emergency context, you don't really have that option of having patients nicely fasted unless they're fasted because they're not feeling great. Now, the other thing to think about too when you're looking for the pancreatic duct, and this is one that I did scan this week, and I thought, oh geez, there's a big pancreatic duct and put the colour on, and it's not a duct at all, it was a vessel. So before you start calling something a dilated pancreatic duct, just pop the colour on to make sure that it is a duct and not a vessel. If there's colour flow in it, it's a vessel, obviously. The pancreatic duct should not have any flow in it. So what are some of the sonographic signatures or the sonographic appearances of pathologies and normal pancreas? The normal pancreas, as I said, has a wide variety of normal appearances. The echo texture can be quite variable insofar as it can be quite hypoechoic, it can be a little bit mottly and indistinguished on your larger patients. And if they have some fatty infiltration of the pancreas, it can be a little more echogenic. It's described in the ultrasound books as a tweed-like echo texture. And I know when my mentor was saying, it's that tweed-like thing, I had no concept of what tweed looked like. So I don't know if that helps you so much, but that was what was imprinted for me when I was learning. And here we have another normal pancreas, and it's a little harder to see on here, but we've got the head coming around here. And the key things that help me find it in this picture, here's my aorta, and here's the vessel, the splenic vein. And so those landmarks are really crucial in helping you find them. And I think the error that I made when I was learning is I was looking for the pancreas, and no one thought to say, find the vessels first, because if you find the vessels, then the pancreas is easier to see. Again, so here we have more the head and the uncinate process. And in this part, we can see the neck. And here we have the body and the tail of the pancreas. And again, like I said, it's also good to just have a quick look in the longitudinal view. Sometimes that can let you see the head of the pancreas much more clearly. So this is longitudinal, and over here we've got the transverse view with the outline of the pancreatic head. So the first common pathology, if you like, or things that we might see on ultrasound is pancreatitis. And the role of ultrasound here is more to determine, like clinically you'll figure out whether this is suspected pancreatitis or not. But the role of ultrasound is more in determining what the cause might be. Are there any gallstones? Is there any bile duct dilatation or any obstruction of the bile duct? You may happen to diagnose an unsuspected acute pancreatitis. And in some settings, mostly radiology and very specialist centres, they might use ultrasound to help guide the drainage of a pseudocyst. So the ultrasound appearances of pancreatitis can be really quite varied. And to be honest, a lot of the time, the pancreas can look completely like all the other pancreases that you look at. They can even look quite normal, but what we are looking for is decreased gland echogenicity, enlargement. That's really hard to define because you don't know what they were before and what they are now. Looking for any peripancreatic inflammation or fluid collections. We're looking for heterogeneous parenchyma of the pancreas, indistinct margins, and pancreatic duct dilatation. So here we've got an example of a peripancreatic effusion and a bit of inflammation and fluid sitting just around the pancreas. So again, we have the aorta here, and we can see the vessel, the splenic vessel here, and the outline of the pancreas. And so up here is our peripancreatic effusion. And we also have a little bit of fluid, which I hope is a bit better delineated in this version where we're concentrating on looking at the tail a little more. You can see this dilated duct in here, and then the peripancreatic effusion continues and helps us to visualize the pancreatic tail in this instance.
So Suean, that fluid is retroperitoneal?
I don't know, just looking at it. I don't know that just looking at it that you can really say. So I think most of the pancreas is retroperitoneal. I think I set up the front there. So it may be, but I don't know just looking at it that we can be really distinct about retro or intra.
Because you can get ascites with pancreatitis as well.
Yeah, and I mean, this is
um,
just little bits.
yeah.
I've not seen it with massive ascites, but this is just
Mm.
little tiny bits of localized fluid collection. And this is a second case where there's a peripancreatic effusion, and not really. I mean, there's a bit of grot in there as well, I guess, but you know, it's not huge amounts of fluid, but just a little bit quite close by.
And I've seen it causing fluid in the gallbladder fossa area, and also causing gallbladder wall thickening,
Yes.
just because it's also close together.
Yeah. The other thing that we can look at, and that's what was the inspiration for tonight's presentation, was pancreatic pseudocysts. And I have to say, I've probably only seen maybe 3 or 4, and it feels like, I mean, not, you don't wish bad pathology on anyone, but it's kind of like, wow, you see something really cool. Anyway, Brian has sent us in some pictures, a couple of pictures this week for a case that he saw, and I'll invite him in a minute to talk through the history. But a pancreatic pseudocyst is defined as a fluid collection, and it's mostly comprised of pancreatic enzymes, blood, and necrotic tissue that is within or adjacent to the pancreas. And they become completely encapsulated with mature, non-epithelialized fibrous inflammatory wall. So they can have quite an echogenic wall to them. Pseudocysts account for about 75% of all pancreatic masses and are typically complications of chronic pancreatitis, but they're often a common sequelae of acute pancreatitis as well. So what you see is that they're a cystic lesion of the pancreas, and they're the most common cystic lesion. And it's important, obviously, to figure out what exactly it is so that you can manage it appropriately. The thing with the pancreatic pseudocysts is that they can cause mass effect, they can cause biliary obstruction, gastric outlet obstruction, and secondary infection. So here's some cases that I have found on the web at ultrasound cases. Here's a lovely big cyst where it shouldn't be. And, you know, they can get some debris in them. And this was the CT films that go with this case. Here's a 6 centimeter pancreatic pseudocyst in the head of pancreas that I scanned quite a few years back, but, you know, and not quite as delineated as some of them can be. It might be, you know, the older machine here as well, that it's just not showing up as clearly, but there's a big sort of cystic area where there shouldn't be one. And here's the case that Brian sent to us. He had a patient present, and he found a cyst where he wasn't expecting to find one. And Brian, did you want to talk us through this case? There was a 5.5 centimeter cyst in the pancreatic tail that was confirmed on the CT scan.
Yeah, I mean, I think on the CT, it's rather obvious what the pathology is, but I was called out of my office. I was on an ultrasound scanning shift, and one of the JMOs wanted me to help him look at a gallbladder because this lady came in with epigastric abdominal pain, and had a look at the gallbladder. The gallbladder looked okay. She was really tender, and just kind of continued to scan along, and scanned a bit of the spleen, and found this mass between the infralateral pole of the spleen and in the left kidney. And honestly, I didn't know what the hell it was. I just knew it shouldn't be there. And I felt rather dumb at the time, to be honest with you, because I don't know, Alan, you guys, I felt rather humbled and wasn't sure what exactly I was looking at, and ended up getting the CT as a result.
I haven't seen any before either, Brian. So we're together on this one.
All I know is it shouldn't be there. And so it got me thinking that I never actually heard a POCUS talk on the pancreas. It's like this organ that we never, ever even think about. And honestly, Suean, I think you're doing a fantastic job. I feel really educated now. I'm not sure I would have traced that back to the pancreas. I'm not entirely certain. The other thing about that cyst is it looked like it had an internal echogenicity to it. I mean, I always thought of a cyst as being an anechoic structure, but I like how Suean pointed out that these are full of debris. And so I thought it was more of a mass at the first instance, but anyway.
I think the most important thing here is, you know, there's gonna be a lot of times when you don't know what it is, you just know it's not right. and that's your job done. You know, I always look at all the possible things that could go wrong when a baby is developing. There are so many different, I mean, I cannot possibly remember all the different syndromes and possible abnormalities that can go wrong. The thing that we're looking for, though, you get used to looking at normal, and you look at normal and you calibrate for normal. And then when you see something out of the ordinary, it stands out. And that's what the textbooks are for. And that's what you have other colleagues to sort of bounce things off. So I think the important thing here is, you know, don't beat yourself up. It's more about knowing that that's not normal and needs further investigation.
Yeah, Suean, and it's a little embarrassing when you're writing out a CT request and you're going, funny thing seen on POCUS, not sure what it is, because it doesn't inspire confidence among in our radiology colleagues. They think, oh, what are these guys doing? They don't know what the hell they're doing downstairs.
I say that an uncommon amount of the time.
They wouldn't be able to perform the ultrasound themselves, Brian.
Yeah.
The other thing in that area I was going to say is often, you know, I think most of the time if we find something in that area, it's obviously much more commonly coming from the kidney, whether it's a large cyst or it's a mass. So I suppose my first instinct, if I saw something in that area, would be it's probably coming from the kidney. But I suspect you probably really carefully looked around the kidney and you could establish that it wasn't in contact with the kidney at any point.
Correct. Yeah, correct. I could tell it wasn't part of the kidney. And, you know, you see hundreds of these renal cysts, and they're anechoic and usually attached to the cortex. And this was clearly separate from it. And I have a couple of video clips that I had saved also that clearly demonstrate it wasn't there. Elias, sorry, I heard you make a comment, but I didn't quite hear what you had said previously. Sorry.
Sorry about that. No, I was actually just saying that it is not uncommon for me to cite on my CT imaging request, like abnormality seen on POCUS exam, not sure what it is, please investigate. Like that's basically just like my justification for a CAT scan sometimes. And honestly, like I work in a very, very small hospital. So like, I think most of the radiologists like come to recognize that like, that's just going to be a thing and they just kind of accept it.
Yeah. Yeah, thanks. I'm glad. It makes me feel better. And it also makes me feel better saying that she hadn't seen, she's only seen a few of these in her career. So this will probably be my last one. So
is it that different? Is it that different to some, like, I mean, that used to happen more, but people would say, I can feel a mass in the abdomen on physical examination. I mean, and then sometimes there was and sometimes there wasn't. So it's not a lot different to that.
and yeah, you could probably scan a lot better than a lot of radiologists in this country. So, you know, they can diagnose it and they can look at the pictures, but to actually, you've got to be able to find it in the first place. And that's where the skill lies, is actually being able to take pictures of it and be able to find it in the first place.
And I think you've also got to be a bit cautious about their interpretation of the ultrasound as well, because I've had at least a handful of cases that I can think of in the last couple of years where I've disagreed with the radiologist's interpretation, and in fact had a leaking ectopic reported by the radiologist, saw the free fluid. This is only just in the last several days, saw the free fluid with a tiny sac in the uterus, no yolk sac, and said, plan review in 2 weeks, probably normal. That was the plan. You know, and so I think, you know, radiologists aren't always right with how they interpret ultrasounds either.
Well, and the good thing about that is you get to clinically examine your patient. And I say this a lot. For you guys, ultrasound is just one piece of a 100-piece puzzle. And, you know, if all the other pieces are pointing towards a picture that doesn't match your one ultrasound piece, you have to rely on your clinical instinct. And I think that's really important. It doesn't matter what part of the body you're scanning. You're a doctor first before you're a sonographer. And if the sonography and the ultrasound is not agreeing with everything else that you're getting signs and symptoms from, then you've got to trust what your signs and symptoms are telling you. Anyway, so we'll move on now to some pancreatic tumours. And I think the pancreatic tumours, again, it's quite, it's nice from a completely nerd point of view, from, you know, hey, I can put that in a talk. It's never nice for the patient. And I always feel just completely gutted. And again, I haven't found heaps and heaps of these, but whenever I do, I know that this is seriously bad stuff going down for the patient. Often when there's a head of pancreas mass or a pancreatic tumour, you may, most of the time you won't see the actual mass, you'll see the effects of the mass. So we have direct signs and indirect signs of a pancreatic tumour. And typically your patient has painless jaundice for investigation. And for me, that patient that comes in with painless jaundice, I know that I have to really look very closely. But again, like I said, most of the time I'm seeing the indirect signs of a pancreatic tumour rather than finding the actual mass itself. Now, here are some cases where, you know, on those times where we have seen the mass itself. And I think it's quite obvious here that there's something going on in this pancreas. So they can be, well, depending whether if they're malignant or whatever, the you know, they can have mixed echogenicity. They can appear anywhere in the pancreas. On this particular one, we've put the colour on and we can see increased colour flow, which is always a bad sign. But that tells me that something's not quite right here. And so we need to be looking for those indirect signs too, whether there's duct dilatation, whether the bile duct's dilated, is that obstruction sort of affecting everything downstream from there? And so what we're looking for here is a hypoechoic mass in the pancreas. You can see pancreatic duct dilatation, you might see common bile duct dilatation, you might see dilated intrahepatic ducts. And in some cases, if that obstruction is quite marked, you'll even see a really big swollen gallbladder. So here's an example of the pancreatic head tumour. So we've got this irregular, sort of poorly defined mass, and it's quite hypoechoic compared to the body of the pancreas over here. So in this one, we can also see this massive, big dilated bile duct as well. So even, and as we go on to the next pictures, that big dilated bile duct is highly suggestive for a mass in the pancreatic head, even if you didn't see the actual mass itself. The tumour itself can present as that hypoechoic structure, but it's more the effects of what the tumour is doing that we can see quite clearly on ultrasound. So again, here's this massively dilated common bile duct. And then in this case, there's dilated intrahepatic ducts. So you can see these sort of in the middle section of the liver there. And again, this is why it's, when you're scanning the gallbladder and looking at the common bile duct, I always get a little worried if I can see the bile duct, you know, every now and then you get that really easy patient where you see the bile duct all the way to the head of pancreas. We need to go looking for it. But if it is really dilated, it makes it, as you can see in this example, it starts to become really clear what it is. But it can also be really confusing because is it a big vessel or not? So then you need to really know your anatomy and trace that back, put the colour on, make sure there's no colour flow in that structure. And here we have the dilated intrahepatic ducts, and they talk about the sort of double barrel shotgun sign here. And we can see that in the right lobe of the liver here, where we've got really dilated ducts. Here's another pancreatic head tumour. So we have a hypoechoic, ill-defined mass. So here's the SMV and the splenic vein starting to track this way, and this ill-defined hypoechoic mass. This one also has a very well-defined and big dilated pancreatic duct. And over here, you can see the dilated common bile duct. And again, you see that sort of double barrel shotgun. So this is the bile duct, and this one here is the portal vein. And for this patient, they had very swollen or enlarged dilated gallbladder, and you can see some sort of echogenic content in there because that bile's been a bit stagnant because it's obstructed. And we have, again, the double barrel shotgun sign in the intrahepatic portion of the bile ducts there, and in the right-hand side of the liver. You can just see those bile ducts are really dilated again. Here's another example of a pancreatic head tumour. And again, the prominence of these ducts, and it might be that the ducts are the first thing you see if you're looking at the liver. You might notice the bile ducts really dilated or something doesn't look right there. And that's when you need to sort of check and see, well, what's causing that obstruction to cause those dilated ducts.
What's really striking about those?
Double barrel shotgun. So we've got hepatic artery here, the bile duct coming underneath, and then here's portal vein. And here's the pancreatic duct in the pancreas. So we've got the vessels here. And again, in this particular image, it'd be handy to have the color on because you'd see that this is a vessel and then this bit is a dilated pancreatic duct. When they're that easy to see, something's not quite right. So I hope that I have made it so that it's more than just this grey Martian moonscape like it was for me when I first started ultrasound. I know for a long time, I used to just keep looking and they'd go, yep, stop there. And I would just push the button and freeze, but I couldn't see the pancreas for the life of me. So I think it's really important that first of all, you go with the things you know how to identify where the aorta is and the SMA. If you can see aorta, SMA, you'll be able to see the splenic vein draping across the top over the anterior to the superior mesenteric artery. And that helps you delineate where the pancreas is. So we've had a quick tiki tour of the pancreas, looking at the sonoanatomy, some scanning technique and scanning tips, and the sonographic signatures. So has anyone got any questions?
Suean, I thought that was fantastic. Thanks a lot for going through that. The last bit we were talking about looking for pancreatic head tumors. I have to admit, I'm not sure I'm going to, in my career, be quite that clever. I think I'm going to see intrahepatic and common bile duct dilatation in a patient who's got painless jaundice and just go, okay, it probably is, and get somebody else to do the study or get an MRI or something. I don't know what you guys think.
Yeah, that's fair enough.
Yeah, I gotta be honest, like that last case, the most striking part about that was just how obtuse the tumor itself was. Like that was really, really difficult to see. Even when you pointed it out, I was like really struggling to be like, I don't know that like there's a fuzzy kind of like non-something there almost, but it wasn't quite like, oh yeah, that's a discrete mass that I can actually identify as like a soft tissue thing. Like that was really impressive. Two other really brief things. One is that repping the POCUS Atlas, just FYI, and I just was looking on their site, and there's actually exactly one case of a pancreatic pseudocyst on there and no other images of the pancreas at all. So if anybody has like pancreatic cases, definitely submit them to the POCUS Atlas. I think that'd be very helpful to have some better representative images there. And third, very briefly, Dr. Desalan is actually, I want to call her out as my very first ultrasound tutor, mentor, inspiration, whatever, back at Metro when I was a medical student, almost 10 plus years ago, which makes me feel terribly old, in addition to the white hairs and the 3 children. So Dr. Desalan, hello. It's wonderful to see your name up there. Thank you for pointing me down this pathway that led me to here tonight.
Cool, thank you. I'd agree with you, Eli, insofar as the mass itself. I think a lot of the times, like I said, it's not like these are an abundant pathology. It's not like renal cysts that you're going to see them all the time. But on the balance of the cases that I've done, I reckon I've noticed the indirect signs much more obvious than the actual mass itself. When the patient comes in and they don't have any pain and they're yellow, and then you see these indirect signs, for me, that's a home run, whether I can see the pancreatic mass or not. And then they'll obviously go on to CT, which will often delineate it a whole lot better than we can on ultrasound, but they can be really, the mass itself can be really wishy-washy and vague, whether you see it or not.
And it was good to hear Eli mention the fact that there's hardly anything out there in the POCUS, emergency POCUS community about the pancreas. And certainly after I had the case, this pancreatic tail pseudocyst, I went back through some of the materials I have, and there's next to nothing in the textbooks or anywhere else. So that's why I think it's really nice, that you took a lot of time and effort to go through this, because I have to admit, this has all been a lot of new information for me, and I'm certainly going to share the link to this with some of my colleagues.
I think too, it's don't just scan this on that occasion when you think you might have something. Make it, you've got to get your eye in for what does normal look like. And as I said, there's a big variety of what normal pancreas looks like. And so practicing just getting those views so that you can rely on your technique for the patient that is, painless jaundice. So if you practice just finding it and becoming aware of it, I'm almost embarrassed to say how long it took me to see it when I first started training, because they didn't point out landmarks to me, and I was just like, just please point to it. It was so frustrating. It was my arch nemesis view until that down the track has been replaced by the aortic valve. But anyway, I think it's important to be establishing your baseline first before you can just go, oh yeah, there's the pancreas. So practice on normal first.
I haven't got any cases of pseudocysts, but I can show you in a couple of minutes a nice pancreatic cancer tumor if you want to share the screen. I've got it up already on a PowerPoint.
Oh, cool. Hang on.
And it presented as GP sending a patient in as query AAA because they felt a pulsatile mass, but the mass was not actually the abdominal aorta. It was the pancreatic tumor sitting on top of the abdominal aorta that they were feeling. The pulsatile mass. So can I share your screen now? Yep. Okay, here we go.
I'll let you know if it's working, otherwise I'll make you host. Oh, there you go.
There we go. I will just go to that. Can you see that okay?
Yes, it's great.
Okay, so yeah, like I said, GP sent in this patient, 70-year-old female, thought they had AAA because they felt this possible pulsatile mass in the epigastrium. But when I talked to her, she'd actually had pain in that area for about a month, which hadn't come out with the history of the GP. Her obs were basically normal. She'd had a little bit of vomiting and also had weight loss and anorexia for a month. So I was starting to get a bit suspicious that this is not AAA, that there's potentially something nasty just on the history. She'd had a gastroscopy 18 months earlier, which is normal, had a gallbladder taken out. So those things sort of sounded okay. She had routine bloods, ECG were all okay. And she had just had this multi-tendon epigastrium and a possible mass, yeah, I think, when it felt, possibly. So let's have a look and see what the pictures showed. Sorry, I haven't got it set up on automatic. But so there's the aorta, and I'm going, okay, I'm starting to see something that doesn't look like it's in the right spot there, and it's on top of the aorta. I wanted to just make sure I was happy with the aorta to start with. And I was pretty happy with the aorta. I wasn't quite so happy, sorry, with this thing sitting up here. And then I wasn't happy with that either, which is sort of a giveaway that something's going on because there's cavitating anechoic lesion, irregular looking lesions sitting in the liver. So I'm thinking, okay, let's have a little bit more of a look. So we went into a long axis on the aorta. I was again happy with the aorta. I think they're both still pictures. Oh, actually, maybe not. What's that one? Hang on. I'll keep going. Just having a bit of problem with my slide. Give me a second. There we go. So, yeah, so, there's the mass, there's that cavitating lesion. I'm not sure what plane I was
in. Alan,
I'm in transverse plane there, there's the aorta. And, decent size, wasn't it? Around about sort of 3 centimeters or so. And there was a cavitating lesion. And I measured, wow. I measured it, and you can see it actually had this sort of funny appearance, almost like, sort of a edema around a tumor, that you get like in the brain with that sort of ring enhancing sort of lesion. And wow. It's clearly broken down in the center of this lesion in the liver. So I think this is, this fluid is actually, you know, that classic necrotic tumor where the tumor tissue is actually broken down and become fluid, and it's got edema around it, and obviously a little bit angry in that sort of area. But other reason to put color on is you don't want any flow in that, because you know, is it something else? You know, certainly it reinforces that this is, you know, fluid or an abscess, or could be an abscess. I mean, you know, but you know, with that other mass, it's not going to be an abscess, it's going to be liver metastases. But you know, I suppose I think I've seen one liver abscess before. Suean might have seen more, whether they could look like this in isolation. You know, pretty decent sized liver metastases. I think there were actually two when I was scanning through. There was a second one in the liver as well. Sort of getting that sense of the vessels coming right up into that tumor mass, as Suean was saying about having, you know, the portal splenic confluence in that area. Yeah, so that was a picture of that mass. Wasn't so hard to spot, but then it wasn't that subtle if you could sort of feel it, and the GP thought there was a mass, and you got that liver metastases as well. So it was pretty easy to say something was going on. It definitely wasn't the aorta. Probably for that patient, it would have been better if it was the aorta, unfortunately.
So Alan, my guess is you clearly knew something was wrong, much like I knew there was something not right, and ordered a CT or something.
Yeah, I mean, it was one of those situations where it did expedite things, in that instead of just doing an aorta scan, you know, like if it was someone who doesn't do ultrasound, they might have said, let's just get a CT abdo, right? But then you would have seen this, and you would have to go back and say, well, we're going to need a chest, we're going to need a brain, we're going to need to do some staging maybe. So, you know, I could order a pan scan knowing that I'm ordering a pan scan for a good reason, which is to stage it. Yeah. So yeah, so she got a staging CT scan, and we were, you know, obviously able to start organising her follow-up straight away, rather than wait a few hours to get this information from a reported CT abdomen, and obviously had to sit down and have a conversation, which wasn't nice to have with her and her family about what it showed, because obviously that was a big surprise to them. They weren't expecting that at all. So,
wow, great case, Alan. Thanks so much.
Yeah, that's super
It's
interesting.
very organised of you to be able to have it there, just on hand.
As soon as you put the pancreas up, I knew go my aorta talk, because I knew it was my aorta talk, because that's why I originally did the scan.
Oh, there you go. There you go. Thank you. Were you going to say something there, Elias?
Yeah, I was going to say, going into this, my initial thoughts were that, like, almost 100% of the time, especially with myself specifically, because I've seen so much like terrifying aortic pathology, like I'm assuming that anything that's vaguely concerning and gross in that area probably going to be coming from the aorta. Like I've seen like a case of aortitis before that like has the vague appearance of like some of the things that I've seen tonight. And you could almost be forgiven for thinking that exact thing, even visually. Like, I mean, it's distinct, but if you're not really like keyed into like actually looking for that specific differentiation, like you could almost be fooled that this is like some kind of like weird saccular aneurysm off the aorta that you're just like, oh, maybe I'm not quite getting the angle right to differentiate the two. The other thing was that I was almost convinced that necrotic lesion in the liver was actually just like either the on the initial images was either the like a really distended duodenum or like part of the stomach or something. And you could like, you know, in the later images, you could actually see that clearly, like, oh yeah, it's obviously like well delineated within the liver itself. But I don't think I've seen that specific appearance before in a liver lesion. That was a really interesting case. Yeah, I appreciate you showing that to us.
I think this just reinforces that you know what normal looks like, and when something isn't normal, that's your cue to refer for other testing that can help figure out what the rest of the pieces of the jigsaw are. And whether it was aorta looking a bit weird or it's a pancreatic lesion, the thing is that it's not normal either way, and that is your cue to refer it for other imaging or to have someone else have a second look. And so it's interesting because I think, you know, we can present lots of cases. I think it's really important to have that baseline reference of normal, and, you know, particularly when people are learning, practice on easy, slim people who are not super sick that you can build that reference of normal. And that's hard to do when you're working in an emergency room where everyone's presenting sick. But, you know, the patient who comes in for maybe query gallstones, that's the patient you can have a look at their heart. Or if they come in for something else that's really innocent, that's when you can look at other things to just build up that baseline of normal.
Have you seen many lesions in the liver, Brian or Suean? I think that's one of those interesting ones that Elias is getting at, where sometimes there's such a range of ultrasound appearance of abnormality that, you know, I'm sort of pretty cautious with that, as Elias says, is like, if I see a simple, it can be quite big. If I see a simple, nice, round, black or anechoic cyst with posterior acoustic enhancement, I'm pretty happy because I've seen quite a few of those, and they can be quite damn big, and sometimes you can have a few. But sometimes you see, you know, one or more lesions that are, you know, slightly anechoic. Oh, sorry, I should say slightly anechoic, hypoechoic. Sometimes they're almost isoechoic. Sometimes some of them are even a bit hyperechoic. And then you've got that unusual one that I just showed you then, that's breaking down in the center with that sort of necrotic degeneration, and then almost like an edematous ring around it. The appearance seems to be so variable for metastatic lesions that I think, you know, certainly for me, I'm often uncertain, so I'm usually getting a formal ultrasound or a CT if I see something, usually as an outpatient a lot of the time. But it seems to be that there's quite a variable appearance, and you can never be sure what's benign, and sometimes even cirrhosis. Some of the cirrhotic lesions can look quite malignant, and even the radiologists often say, "Oh, I'm not sure whether this is just cirrhosis or whether this is malignant. You need a biopsy."
No, I haven't seen a lesion quite like that one in the liver, that's for sure. And I'm not sure, I guess the people who are used to dealing with metastases, you know, if they're breast metastases, they have a particular appearance, and to kind of sit in it right in this moment and say, here's what they look like versus these ones, you know, I can't do that. But there is a big variety of appearances of metastatic lesions in the liver. And I think it partly is where they come from and how they look.
You're right. What's the primary, isn't it?
Mm. Does anyone else have any questions or suggestions for next month's topic for the Coaching Corner? Thanks very much, Brian, by the way, for suggesting tonight's topic. It was good. I enjoyed it. Does anyone else have any suggestions for next month's topic?
Have we done shoulder dislocation?
No,
we haven't.
We could do
I'd be
that.
down for that. Alternatively, based on our conversation a couple hours ago, Suean, some nerve blocks in the future would be always appreciated.
Yeah, cool.
Got a couple of images from my own repository I could send you, and I'm sure others have much better ones.
Sounds
Love
good.
to see yours. I don't have any.
I might have a couple of months topics there. It's good. All right, then I won't keep everyone any longer. Thanks so much for coming along tonight. It's good to see your faces. Although we're not locked down, it's also just good to see people from around the world. So thanks so much for tuning in, and we'll see you same bat station, same bat time next month, first Thursday of the month at 7:30. Thanks, everybody. See ya.
Good on you, Sam. Thank you.
Thanks so much.